Hello everyone, my name is Victor Kwazi. We've prepared a short video presentation for you on the interpretation of the audiogram together with Dr. Damian Holsinger. We also acknowledge Jujet, who is one of our students, for kindly allowing us to use her audiogram for this presentation. Our learning objectives are essentially to understand the indications for pure tonal geometry. We're also going to look at the pure tonal geometry chart, which plots the hearing threshold in decibels vis-a-vis the frequency of sound in hertz. We're going to understand how to interpret the pure tonal geometry charts, and lastly, describe the clinically relevant and applied anatomy. This slide reminds us of the organization of the ear, whereby we have the external ear from the auricle through the external auditory canal, and we have the tympanic membrane separating the external ear from the middle ear. The main function of the external ear is channeling the sounds from the external environment into the tympanic membrane, where the sound waves are amplified further. The tympanic membrane separates the external ear from the middle ear. Within the middle ear cavity, we have the eustachian tube or the pharyngotympanic tube, connecting the anterior wall of the middle ear cavity to the lateral wall of the nasopharynx. This is important for equalization of pressure between the middle ear and the external environment. Within the middle ear, we also have the ossicular chain. So you have the malleus, incus, and stapes. These three bones or ossicles are joined together by synovial joints. And they also help to further amplify sound from the vibrations of the tympanic membrane. And the footplate of the stapes connects to the oval window, which is in continuity with the scala media within the spiral organ of Corti. In the inner ear, we get the vestibule, which actually separates the semicircular canal superiorly, the footplate of the stapes laterally on the oval window. Inferiorly, we have the 2 complete turns and 1 3/4 turn of the cochlea, and medially we have the cochlear nerve. So describing the pathology of the ear, essentially, if you have a problem in the external ear or the middle ear, one experiences conductive hearing loss, whereas a problem with the inner ear causes sensory neural hearing loss. In this presentation, you're going to understand how to distinguish these two types of hearing loss using pure tonal geometry. So a pure tonal audiogram may be defined as a graph that displays the hearing threshold in decibels on the y-axis against the frequencies of sound, which are gradually increasing, and these are denoted in hertz. The indication for pure tonal geometry include objective assessment of hearing to quantify the level of hearing loss, such as mild, moderate, severe, or profound. Mild hearing loss is described as hearing loss between 25 and 45 decibels, moderate between 45 and 65 decibels, severe between 65 and 85 decibels, and profound hearing loss is sound hearing loss above 85 decibels. Normal hearing is usually below 25 decibels. The pure tonal geometry is also an objective test that we may use to monitor therapy, such as after cochlear implants and using hearing aids, and also for rehabilitation purposes. So generally, we plot the two graphs using different color codes. Conventionally, the right ear is plotted using the red graph and the left ear using the blue or black symbols. We'll also notice that we have conventional signs that we use, such as the red circle, we use it for air conduction, and the blue X for air conduction on the right and left ear respectively. So again, just to remind us of these symbols, if you're looking at this graph, this first one is made up of the red circles, and the first hearing threshold is at about 250 hertz, and you can see at 250 hertz we find a hearing threshold of 10 decibels, and on the right ear it actually ranges from 5 decibels to 25 decibels. So this is within normal hearing range, the hearing thresholds at different frequency. And we can say this particular person has normal hearing, normal air conduction in the right ear. But if you remember the case on your assignments, which we discussed during the practical, this person had some kind of hearing loss. That's why you're doing this test. But when you do the air conduction, it appears normal, within the normal hearing thresholds. Looking at the left ear, again, the hearing thresholds range from 5 decibels to 25 decibels, 5 to 25, as the frequencies increase. And once again, air conduction in this person is within normal range, which is below 25 decibels. So this person, you can say, has bilateral air conduction within normal range. So that rules out conductive hearing loss in this person. There are other tests that we do, such as masking. And masking means blocking off the interference from the external environment. So we use devices that look like earphones in order to block the external sound. We also do bone conduction that tests for the cochlear nerve function. So these are the symbols we use for bone conduction. We have the closing brackets for the left ear and the red opening brackets for the right ear with masking. Without masking, we find this slide is a little confusing. This is more accurate. If you do bone conduction on the right ear, with unmasked ear is a less than sign, which is conventionally read. So this is correct in unmasked ear. And when you do masking on the right ear, we get opening bracket on the right ear. So this is also accurate, opening bracket on the right ear. However, on the left ear, it's when you do unmasked, it's the greater than sign. So forgive my typo. Should be the greater than sign for bone conduction, and should be the closing bracket when you do masking, as Georgette has correctly pointed out. So the purpose of masking, as we mentioned, is to block off the interference from the environment and objectively assess bone conduction. So what is the reason why we do pure tonogeometry? First of all, we do pure tonogeometry to determine the hearing threshold. So if you look at this graph, as we mentioned, air conduction is within normal range on the left and the right ear. Whereas if you look at bone conduction, which we mentioned on the right ear, the right triangles actually depict the right triangles depict the masked air conduction, which tests bone conduction. And you can see there's decreasing hearing threshold as we increase the frequency. So the pure tonogeometry helps us determine from which particular frequency do we lose the hearing threshold, and it's within which range. So it can either be mild, moderate, severe, or profound. It also helps us determine the degree of hearing loss, as we've mentioned. We can quantify whether it's mild, moderate, or severe. And more importantly, it helps us distinguish whether it's conductive hearing loss or sensory neural hearing loss. So once again, looking at Georgette's audiogram, we can see the air conduction was normal in both ears. But if you look at bone conduction, it's gradually decreasing within specified ranges. So if you look at the right ear without just bone conduction, and when you mask it, we find the red triangles gradually decrease between 25 decibels to about 60 decibels. So looking at that hearing threshold, we're talking about a range of mild to moderate hearing loss on the right ear. And we can say it's sensory neural because you're looking for bone conduction. And looking at the left ear, again, if you do the same masking on the left ear, which is shown as the blue rectangles, And we can see the hearing threshold is also decreasing on the left ear, starting from 50 decibels to a lower limit of 75 decibels. So in this case, we're talking about a hearing threshold that is mild to moderately severe in the left ear. So we confirm this by doing bone conduction on its own, and again bone conduction with masking in both ears. But the pattern is more or less similar if we do the assessments of bone conduction. So objectively, we can tell that this person has bilateral hearing loss within with bone conduction. I mean, the bone conduction is gradually decreasing in threshold as we increase the frequencies. The other thing that we notice is an increase between the hearing thresholds in air conduction and bone conduction. And that widening gap is what we describe as the air-bone gap, meaning that air conduction is significantly better than bone conduction. So you get a gap between the two, which is known as the air-bone gap. We'd also like to remind you about the other tests that we also use to assess hearing apart from pure tonogeometry. So we use Reinys and Webers. In Reinys, we compare air conduction to bone conduction. In normal hearing, the air conduction is usually better than bone conduction when you do that using a tuning fork. In conductive hearing loss, we get bone conduction getting better than air conduction, and we refer to that as Reinys negative. Some of the causes of conductive hearing loss include wax impaction, perforation of the tympanic membrane, osteospongiosis or osteosclerosis of the middle ear ossicles, or fluid accumulation within the middle ear space, such as in otitis media, or cerebrospinal fluid accumulation within the middle ear. The treatment for conductive hearing loss essentially depends on the underlying cause. We can do ear syringing for wax impaction. We can also use hearing aids for amplification of sound. In sensorineural hearing loss, usually the Weber's test is lateralized towards the beta cochlea, and there's reduced hearing on the side with sensorineural hearing loss. Some of the causes of sensorineural hearing loss include presbycusis, and by the age of 75 years, about 1 in 2 people have sensorineural hearing loss, which is age-related. The other problems we have include sociocusis or nosocusis. This means either extrinsic or intrinsic damage to the inner ear. And some of the causes of these problems include cochlear nerve damage, such as by labyrinthitis, which might be due to viral infections. Though in most cases, labyrinthitis has no known underlying cause. We also have ototoxic drugs, such as antibiotics, such as streptomycin, gentamicin, amikacide, or generally the macrolides group of antibiotics. Non-steroidal anti-inflammatory drugs, such as aspirin and ibuprofen, have also been shown to cause sensorineural hearing loss, as well as chemotherapeutic agents, such as vincristine and cisplatin. The treatment of sensorineural hearing loss include cochlear implantation. So again, just to remind us of the air-bone gap, which is the differences between the air and bone conduction. And as we mentioned, it's usually widened when there's sensorineural hearing loss. And that just shows, like in Georgette's audiogram, that air conduction is significantly better than bone conduction. We're going to look at the types of hearing loss that we've already mentioned. We have 2 main types of hearing loss: conductive hearing loss and sensorineural hearing loss. We use the objective tests, again, Reinys and Webers, and then we can also use pure tonogeometry, as we've seen, in order to determine the degree and type of hearing loss. We also have what it refers to as specific hearing loss, whereby in nose-induced hearing loss, you get notching at a frequency of 4,000 hertz. And when you do that, you can actually use this figure to infer that a person has noise-induced hearing loss. It's just a common pattern which is non-specific to, it's not a diagnostic per se, but just suggests that this type of hearing loss might be because of a noise damage to the cochlea. This one is what we refer to as socioacusis. And like drug-induced hearing loss, as we saw in the previous slide. Age-related hearing loss is seen in 1 out of every 2 by the age of 75, and it's usually bilateral and symmetrical sensorineural hearing loss. So this pattern might be consistent with the age-related hearing loss. As you can see, it's symmetrical, more or less they follow the same pattern and decreasing at higher frequencies, which typically describes what we see in age-related hearing loss or presbycusis. We have a few limitations of pure tonogeometry. For example, it can only measure sound thresholds at specified frequencies. For example, if you have a hearing loss between 500 and 250 decibels, we cannot really tell the hearing threshold at that level. It only measures at very specified intervals. So you have from 250, 500, 750, 1000, all the way till 12,000 hertz. It can also not localize sound, which is a function of the auditory pathway and the primary auditory cortex. And you cannot interpret speech, so it's very monotonal in terms of speech interpretation. It has no value with speech interpretation, and it's not useful when you want to map out the areas of cochlear damage, such as in inflammation or neuropathies. And as you mentioned in the previous slides, it is very important to use the other tests, such as Raynaud's and Weber's, as well as evoked auditory brainstem responses, in order to fully investigate any type of hearing loss. In summary, we'd like to emphasize the value of pure tonogeometry as an objective test for assessing hearing loss, but as you mentioned, it has non-limitations that we should be wary of, such as it cannot localize speech, it cannot tell the hearing loss between specified frequencies, which it typically describes those hearing loss within the frequencies, and more importantly, it cannot be used in isolation, because for every patient we need to do a thorough history, do good clinical examination, do the other non-invasive and less expensive tests such as otoscopy, and we do Raynaud's and Weber's tests as well, and then just use pure tonogeometry as one of the battery of tests that we use in assessment of hearing loss. It's an objective assessment of hearing loss. Fortunately, we can use it to quantify the type of hearing loss as mild, moderate, severe, or profound. And once you get our results, again, we usually treat these patients according to the underlying cause of the hearing loss. Once again, we'd like to thank Georgette for allowing us to use her audiogram for this presentation, and we thank you very much for your attention.